The main principle of internal fixation for fracture care, most commonly intramedullary nails or plate and screw fixation, is to create a stable construct that will allow the fracture to heal in proper length, alignment, and rotation. 2, in open fractures, early administration of intravenous antibiotics is important to avoid infection. An external fixator is used when the wound is grossly contaminated, and definitive treatment of the wound is delayed until the wound is sufficiently clean. Early wound coverage is important. 3, early diagnosis and treatment of compartment syndrome is important in order to prevent irreversible damage to the muscles and the nerves, which is time sensitive. Emergency fasciotomy by releasing the tight fascia is a limb-saving procedure. 4, fractures of the scapula are typically the result of a high energy trauma with a high incidence of associated injuries that typically involve the ribs and the lungs. 5, the shoulder is one of the most commonly dislocated joints, and most dislocations are anterior. Posterior dislocations may be missed and are typically associated with seizures or electric shock. Anterior, posterior, and axillary views of the shoulder are necessary for the diagnosis. 6, isolated humeral shaft fractures are usually treated conservatively. The radial nerve spirals around the humeral shaft and is at risk for injury. Therefore, a careful neurovascular exam is important. The patient should be checked for wrist drop. Hemorrhage from pelvic trauma can be life-threatening. An important first line of treatment in the emergency. 1880. Introduction. Every physician. Osgood-Schlatter disease, 1918. Department is resuscitation of the patient with fluids, including blood, and the application of a pelvic binder or sheet that is wrapped tightly around the pelvis to control bleeding. 8, in spinal injury, spinal stability must be assessed, and the patient should be immobilized until there is further understanding of the injury. A computed tomography scan is more reliable in assessing spine injury than plain radiographs. 9, spinal cord injuries can be complete or incomplete, and every attempt should be made to avoid further injury. Patients should be triaged to trauma centers since trauma center care is associated with reduced paralysis and improved outcome. 10, according to the Centers for Disease Control and Prevention and the National Health Interview Survey, approximately 55 million adults have been diagnosed with some form of arthritis. This number is projected to grow substantially in the future. A combination of non-steroidal, anti-inflammatory medica, Sion's, physiotherapy, and weight loss with the help of a dietary consultation and physical therapy are typically the first line of treatment for knee osteoarthritis. Weight loss of as little as 11 lbs 5 kilograms has been shown to decrease the risk of developing knee osteoarthritis in women by 50%. 12, minimally invasive surgical techniques improve cosmesis and allow for early rehabilitation. However, they may be associated with decreased visualization intraoperatively, associated risks of component malposition, intraoperative fracture, orthopedic surgery. Anyone who cares for patients in an outpatient or emergency room setting will find that the majority of presenting complaints involve the musculoskeletal system. A basic understanding of the principles of care for musculoskeletal conditions is essential for the healthcare profession. For physicians, the field of orthopedics offers an array of subspecialties with such diversity that it seems that there is something for everyone. Trauma specialists have the satisfaction of physically putting complex fractures back together. Sports medicine offers remarkably rapid recovery in athletes who have suffered fibrocartilage and ligament tears with ever-improving arthroscopic techniques and instrumentation. Spine surgeons see remarkable results from their minimally invasive microscopic techniques while also managing massive disease, 1918, epiphysis, 1918, congenital talipes, deformities with new instrumentation and open surgery. Joint reconstruction is one of our most exciting subspecialties, working with orthopedic bioengineers to develop improved designs, biomaterials, and minimally invasive surgical approaches for faster return to function for patients debilitated by arthritis and injury. Musculoskeletal oncology offers the intellectual challenge of arriving at appropriate differential diagnoses, as well as the technical challenge of limb salvage and major reconstructive surgery. Pediatric orthopedics is an especially challenging and rewarding subspecialty because of the remarkable ability of children to heal their fractures quickly and remodel their bones. The incredible array of congenital and developmental disorders makes pediatrics a uniquely intellectually challenging field as well. The authors hope that our readers will share our enthusiasm for orthopedic surgery and all of its subspecialties: trauma, sports, spine, joint replacement, musculoskeletal oncology, foot and ankle, hand and pediatric orthopedics. E, figure 43:1. Types of fractures: A, normal home, transmine, C, oblique, D, spiral, E. Segmental, F, command, orthopedic trauma. Introduction: musculoskeletal martes resulting from trauma include frac. Toots of bones, damage to joints, and injuries to soft tissues, long bone fractures can be described in transverse, oblique, spiral, segmental, or comminuted figure 43:1. The goals of treating musculoskeletal injuries are to restore the normal anatomy, stabilize fractures to allow Marley mobility, and minimize complications related to multiple system trauma, and to repair, reconstruct these injuries to restore function. Fractures frequently result from high energy trauma as well as from falls onto an extremity, figure 43. 2. The majority of fractures can heal well with immobilization, which stabilizes the fracture while new bone FMM at the fracture site. Methods of immobilization can vary and depend on the fracture being treated. The most common tool used in orthopedics to treat fractures is immobilization with a splint, salt, or braces, and figure 43-2, trantibia fracture and segmental fibula fracture. Their proper application is important to successfully treat the injury without causing additional problems. A successful splint contains adequate padding on the underlying skill over bony remanences and prevent pressure or burns that can be caused by plaster. Splints, which are not circumferential, preferred for acute injuries because they allow room for swell ENZ that inevitably occurs after a fracture. The splint may later be changed to a cast as the swelling odds. Fractures that are displaced or angulated require colossal reduction to properly realign the home. This is done using analgesia, local or general anesthesia, and often muscle relaxation. Reducta is performed with axial traction and reversal of the NW chanism of injury in order to restore length, rotation, and angulation. A splint is then applied and can be gently molded to help end the reduction in place. It is important to obtain x-rays after a closed reduction to verify acceptable alignment of the fracture and to perform a neurovascular ESAM to ensure the pint is not too tight or that manipulation did not change. The vascular static careful monitoring will timely clinical and radiological. FUM necessary in the outpatient setting for certain fractures, splint, or cast immobilization is equate. And in these instances, internal fixation or external fixation is used. A variety of implants can be used to stabilize the fracture, such as screws, plates, rods, and external fixators. The main principle of orthopedic implants for fracture gait is to see a stable construct that will allow the fracture to heal in proper length, alignment, and rotation. Screws can be placed 1+ lactose of fracture to create compression at the fracture site, which promotes healing. Plumes can be placed on the cortex of bones and held with screws, which creates a long area of fixa-non to dialyze the fracture. Intramedullary rods are commonly used for long bone fractures, such as the femur and tibia fig 13-3AB umili. The fracture is reamed prior to the insertion of the rod into the intramedullary canal. Screws can be placed across the cortices of the bone through eye moles in the mod pumal and distal to the fracture to create a lock construct that further stabilizes the rod. When the fracture is locked proximally and distally, this is called static locking in situations where patients are severely injured and cannot safely undergo more invasive open surgery. Damage control orthopedics done by utilizing an external fixator. External fixators also used when the soft times are too swollen or injured to allow for surgical incisions to be safely made. The wrinkle test is helpful in guessing the most suitable time fast definitive surgery. An external fixation device can be used to temporarily immobilize the fracture, especially if the fracture is open and contaminated. External fixators and valve pins placed into hum proximal and distal to the fracture through healthy use, which are then connected by strong rods on the one of the extremity, creating a stable construct. Open fractures. An open fracture occurs when the bone heats through the skin. These typically result from high energy injuries and are often associated with significant damage to the surrounding sofas and contamination of the wand. These injuries are classified into 3 types according to the Castillo-Anderson classification. Type I and injuries, low energy in wounds are anally less than 1 cm. Type IL injuries have a wound length of 2 to 10 centimeters, will migrate soft tissue damage and wound continuation. 1881, Chapter 43, Orthopedic Surgery, 1882, Part, Second Specific Considerations. A, Figure 43-3. A, Transverse femur fracture. B, Intramedullary rod. Type 3 injuries are high energy wounds, usually greater than 10 centimeters in length with extensive muscle devitalization. The wound is highly contaminated with extensive soft tissue damage. These injuries require immediate administration of antibiotics and irrigation and debridement of the wound. The goal of a B figure 43-4, A. Gustilo-Anderson fracture type 2 open fracture, B. femur fracture. The treatment is to achieve fracture healing and to prevent wound infections and osteomyelitis. They are frequently associated, 2, with injuries to surrounding vessels and nerves, which must be addressed as well. When the wound is contaminated, an external fixator is initially used, figure 43-4AB. Often, definitive treatment of the fracture is delayed until the wound is. Image of external fixator of the tibia. A. Compartment syndrome of the forearm. Figure 43-5. A. Image showing compartment syndrome of the muscles. Sufficiently cleaned and healthy soft tissue is available to cover the fracture. Early coverage of the wound is important to avoid infection. Usually a large wound in the proximal or middle third of the tibia can be covered using local muscle flaps, while the distal third of the tibia will require a free flap. In general, an increase in Gustilo grade is associated with an increase in infection risk. Compartment syndrome. Compartment syndrome is an orthopedic emergency caused by significant swelling within a compartment of an injured extremity that jeopardizes blood flow and microcirculation to the limb. Increased pressure within the compartment compromises perfusion to muscles and nerves and can cause ischemia or necrosis. Patients complain of pain that is greater than expected for the injury or surgery. There may be an increase in analgesic requirements. Early high index of suspicion is necessary for timely diagnosis and treatment of compartment syndrome. The usual clinical findings are pain,